Hello, I am Anupama Ganga. I work as a physician in Boomerang Healthcare in the San Francisco suburbs. Just got introduced as a graduate from CMC Vellore. I hold that very close to my heart, and I thank Dr. Venugopal and Dr. Mrinal Joshi for having me here. This is the second time I am presenting in this presentation, and I'm hoping, good morning to everybody. I'm hoping it'll be useful, hoping it won't be boring, and you'll take something from this presentation. My presentation last year was more about a broad view on orthobiologics. This time, I thought I'll talk more about one specific part of it, which is platelet-rich plasma injections and do's and don'ts. Um, Moving forward, um, so platelet-rich plasma, previously known as part of regenerative medicine, now called more as orthobiologics because there are so many aspects to regenerative medicine, is one of the most used, most widely studied, has been there and tried for decades now. Its scope in regenerative therapy presents itself in different populations who have had musculoskeletal injuries. It's used in skin healing, hair growth, but we are mainly focusing on musculoskeletal injuries and its use. So as we all know, there is a rising population of the aged and the elderly. Demographics show that it's definitely shifting in that direction. Um, since 1990, there are studies that show that there's a 113% increase in osteoarthritis compared to a few decades ago. Knees are most affected and followed by hips and hand. So this is definitely a group of patients where platelet-rich plasma can be used. The other scope is people with musculoskeletal conditions, injuries due to various different reasons. If you take young children and growing bones, muscles, and tissues, there is a lot of stress on it. People are competitive, want to do more. At a very young age here in the United States, kids start with gymnastics and tennis, even as young as 3 to 4 years old. It's probably the same trend back in India too. So these are tissues which have not grown to their adult stage. So there is young cartilage that is getting injured and needs healing earlier than later. So that's one group of people who deal with musculoskeletal issues. The second group is the adult group of people who get injured when they are when the catabolic state is more prominent than the anabolic state. So once you hit 25, 30, and you're active and continuing to do the things that you were doing during your second decade, you find that group of people with multiple musculoskeletal issues. And the other group of people is the older generation. Once they are older, there's loss of balance, proprioception, more falls, or less movement, all of it causing secondary degeneration or secondary injuries, causing secondary OA. Um, other than these conditions, regenerative therapy or here PM&R, platelet-rich plasma, I'm sorry, is there's more scope for this because the outlook of people who have musculoskeletal injuries has changed. We have all seen when, at least when I was younger, my aunts and uncles, grandparents kind of went through life, and by the time they hit 50s, 60s, 70s, aches and pains kind of took over, but it was never made a problem. People decided that this is the way life's going to be. Took a step back, moved less, sat on their favorite armchair for a long time. But this was, I don't know if this was by choice or because there was more aches and pains that they had to deal with. Um, But now our generation and definitely the generations in the future are not going to look at the fifth, sixth decades in that view. It is going to be more about how can we continue to stay active, how can we continue to be independent. So there's a huge scope in that field as well. Out here in my practice, I can think of a couple of patients who are, 98, 102 years old. They still come to me and they say, I still want to play bridge. I want to be able to sit. What are you going to do for me? So, a huge paradigm shift out there in how musculoskeletal injuries will be looked at in the future. And this is one set of people. There's obviously more awareness, and people want to prevent injuries. So, addressing injuries or issues with your muscle tendon joint earlier on is becoming priority. And this is where regenerative medicine, orthobiologics can play a good role. These images, I actually took them from websites from big universities where when they talk of osteoarthritis, they do not show images of that hand or this knee. The images that show come with osteoarthritis is this of people enjoying life and this of people walking with their bicycles. So that's the kind of scope we are looking for. We still don't have a cure for osteoarthritis or musculoskeletal injuries. They all heal by scarring, but we are at least trying to manage it and prevent progression. That's the direction that orthobiologics are looking at right now. There's promise, but still a lot to learn and move forward. So, in brief, platelet-rich plasma specifically has shown promise in treating tendinopathies or small partial tendon tears. It helps. So, the tendons we usually take care of is a lot of studies about the extensor tendons in the forearm, the rotator cuff, the patellar tendon, the Achilles tendon. These are the most commonly treated tendons. Acute muscle injuries where there are partial tears of the gastrocnemius, sometimes the biceps, many times the hamstrings. We do try to treat them with platelet-rich plasma. Early osteoarthritis and osteochondral lesions. Late. Usually, people come to you when everything else has failed, but there's more and more data out there which shows that early osteoarthritis, early patellofemoral syndrome. These are the places where platelet-rich plasma would have a better promise when injected directly into the joint. And so in post-surgery cases or during intraoperatively, platelet-rich plasma is used to strengthen, suturing of the torn tendons or the ACL. Going a little bit into history of platelets and platelet plasma, we go back to the 1840s where one of the papers that I was reviewing said that Julius Bezorzero, he named platelets as Le Pesterine del Sangue, meaning, a structure in blood. From here, it has risen to the significance that we have now. We know how growth factors work, how platelets can cause healing. Into the 1940s, played a big role in skin grafts, helping with wound healing with thrombin, fibrin, and platelets. In the early 20th century, came up to prominence with concentration of platelets, helping with thrombocytopenia management. However, the life of platelets was very short. We did not know how to make it survive longer. So that got addressed when EDTA blood packs came into play. Plastic bags came into play to protect and store blood and platelets. And from there on, it has taken on a whole life of itself. The word platelet-rich plasma was coined around the 1950s. One of the first papers was Kingsley et al. From there, we have come to now 2005 when in-depth study was made about the effects of growth factors on tendon and tissues in humans. So now, in today's day and age, we use platelet-rich plasma in treating degenerative disorders as well as healing tendons, ligaments, muscle, and cartilage. So we do use the word healing. It heals when it's used early in the early stages. In the later stages or in severe osteoarthritis, there is a role, but the role is more with limiting inflammation and decreasing pain. That also improves function. So that's how you can see PRP working. So, speaking a little bit about platelet-rich plasma, it is autologous plasma, which means blood from the same patient, which is centrifuged and contains a higher concentration of platelets than in vivo plasma. The concentration can be anywhere between 2 times to 8 times the concentration of platelet in autologous serum, and that's the amount of platelets that's required to help with healing. Again, even 2 times to 5 times, I think, is significant. Sometimes when you concentrate platelets higher up, there is less plasma, so there are less growth factors that are present in the plasma, and so anywhere between 2 to 5 times the concentration is recommended. This is a slide from my last year's presentation. Basically, how does platelet-rich plasma work? One of my mentors used the analogy of paratroopers dropping from helicopters or from aeroplanes into the place where they need to go to. So when there is when there is inflammation, injury, or a chronic inflammation where acute inflammatory markers cannot get there easily, placing an injection of platelet-rich plasma helps trigger the acute inflammation in a chronic inflammation setting, and releases these growth factors, which in turn improves and produces angiogenesis, bone regeneration, long-term healing, cell growth. So that's the role of PRP. It helps with producing the growth factors that is necessary to produce healing. We use 2 kinds of platelet-rich plasma. There is a huge debate going on. The vote is not done on which one's better than the other, but definitely, if you do not want to cause pain, do not use leukocyte-rich PRP. So leukocyte-rich PRP causes more inflammation because WBCs in it cause more inflammation, and there's more pain. But the counter argument is that more acute inflammation, more scope of healing, so more beneficial. Overall, the recommendation is to use platelet-rich PRP in tendinopathies and leukocyte-rich PRP in tendinopathies and leukocyte-poor PRP in cartilage pathology or in joints. Recently, there's been a study, I think it's from Philadelphia, where they tried, one knee platelet leukocyte rich, the other knee leukocyte poor, and they did find some data to say that leukocyte rich had better outcomes, but again, as always, require more studies. While we are talking about regenerative therapy and platelet-rich plasma and injections, we being physiatrists, we know that this is not the only thing that helps with healing and function and returning back to the quality of life that we are looking for. So I really like this phrase, the regenerative rehabilitation, because regenerative medicine without rehabilitation really does not do much. It's important to stress the tissue in the way it needs to be stressed to rehabilitate and work. So this is actually this group or a consortium was came into existence with some of the universities here in the Bay Area, Stanford, UCSF, and then Harvard on the East Coast, and I believe Pittsburgh as well. So these universities and pioneers here came up with this phrase, which is defined as application of rehabilitation protocols and principles, together with regenerative medicine therapeutics to achieve optimization of functional recovery, repair, and remodeling. It involves physical therapists and physiatrists who are interested in regenerative rehabilitation. There is an international consortium, and it would be awesome if you know the tertiary care centers in India could look into this and participate in it as well. So, a small word for regenerative rehabilitation. Getting to PRP injections itself, I thought I would go over a checklist of exam and what we should do pre-treatment, during treatment, and post-treatment. I think that kind of I might take more than 25 minutes to do this. I'll try to rush through. So anytime you're planning to do an injection, during training, I have a lot of people who come up and they say, "Oh, can we learn injections?" Um, I do not believe in just learning injections. My belief is to look at the kinetic chain. Many times I send patients back saying, okay, no injections. Even if you've come here for injections, we have to first work on, your biomechanics. We have to first work on strengthening certain group of muscles before we consider PRP or any other biologics. So listening to your patients comes first. Listen to them, find out what their problem is, where your treatment can be applied, and look into your bag of therapeutics that you have. Use all of them, including orthobiologics, to help them heal and get better. So listen to your patients, give importance to history, because the medical history, we know inflammation is not just from injury. We know there are precursors to inflammation. We know diabetes, poor sugar control can cause inflammation and tissue damage, decreased oxygenation from coronary artery disease or peripheral vascular disease, thyroid issues, gut flora, we know, has a huge role in producing the biomes that can affect your tissue health. And malignancy changes the whole dynamic of the tissue. So these are important personal medical histories that play into how your injection can help. And the next part is personal history, which is sleep, any kind of habits which can affect your tissue health, hydration, nutrition, stress supplements, everything that we always talk about to keep under check will affect how your injections help with healing. An appropriate physical exam. I still carry the exam that I've learned during my training at Vellore, and after. I like to do a thorough, full physical exam. My initial visits are really pretty long initially, because that's when you really get to know your patient, and you have to think kinetic chain, not just the joint or muscle or ligament that's injured. You think about addressing the whole kinetic chain. A dynamic bedside exam helps with this issue, and if you have access to ultrasound, musculoskeletal ultrasound, to make a movement, if you do a test, like say for the shoulder, you do your NIRS test or empty can, full can, and look at it dynamically with ultrasound, it would give you more information as to where your injection needs to go. And when you are looking for your musculoskeletal exam, you can think of your exam as structural exam and functional exam. So it's like the hardware and the software in a computer system. So the hardware or the structural is your bony parts, the joints, ligaments, muscles, fascia, any tissue that is there for you to examine. And the functional or the software is the alignment of each tissue with the other, because when there is an injury, there is maladaptation, and you have to correct that maladaptation for your injection to work. Without that, it's not going to serve the purpose that you're looking for. So alignment is key. Flow of movement is key. Again, the kinetic chain, and the myofascial tissue, how much stickiness is there between your fascia and your muscle and your joint, leads to how much range of motion you can gain from your movement. And making sure you have good range of motion will again help your injection to work. So that's alignment and flow. And then the most important is how well are you able to activate this tissue. So that looks into the health of your nervous system and how the nervous system can trigger the endpoint to move appropriately. And here again, we see how just injecting something is not going to help. Using all your other modalities to help the structure to come to its best tensile strength will add on to biologics. So, like I said, my exam's usually pretty prolonged and long. This was a checklist is one of the presenters at one of the conferences I went to came up with. So he said this takes 2 minutes, this exam. So I wanted to put it into the slide. So when you do a quick myofascial screen, moving the large joints in your body kind of helps you understand how the axial skeleton moves as well as how the peripheral joint moves. So if you're moving your shoulder joints, it shows how your scapula moves with relation to your spine. And so basically do your shoulder abduction, flexion, internal, external rotation, and see how the joints move. Um, you To finish it within 2 minutes, you need to move from sit to lie down to stand. So while you're seated, you check your shoulder joints. Once you're done with that, you do your straight leg raise testing in seated position. You check your spurlings for your neck, the brachial plexus. Even though we don't give much importance, thoracic outlet syndrome was talked about a lot, and then the surgical treatment for it did not really go well. The outcomes weren't as promising as we hoped it to be. So brachial plexus involvement with due to myofascial issues kind of was sidelined, but there's a huge component. Whenever there's a neck issue, the supraclavicular space where the brachial plexus runs definitely gets involved. So addressing it separately is crucial to health of the shoulder or the neck. And lying down, check for quad flexibility. The quadratus, because it crosses over the two joints, it also helps you with assessing the hip and the knee. And moving along from there, spine range of motion in all phases, and then posture exam while standing, because this kind of tells you where your center of gravity is with relation to the rest of your joints. We know how, again, going back to the kinetic chain, if you have hip arthritis, you tend to flex and walk. Because you're flexing and walking, you're now extending your back a lot more than you should be, just to keep your center of gravity where it should. And this causes lumbar facet arthropathy. So um, we have to look at the kinetic chain anytime we are thinking musculoskeletal. I also added, this is not part of the 2 minute screen, but in people who can tolerate a little more stressing on their tissues, heel walking, toe walking, heel raises 10 times, duck walking where you are squatting and trying to walk, and push-ups. These again check the strength of your joints, muscles, and joints. So this would be a quick exam that would help you to screen the joints that you're planning to inject, or even muscles and ligaments. So this is like a cheat sheet, which I think so. Pain uh, was considered the fifth vital sign. It was a very profound thought, because pain would remind you or tell you something's not going well, address it. However, here in the United States, it took a really ugly turn, and pain was thought, pain got processed as chronic pain, which needed to be snubbed, and opiates took a huge, ugly turn on people out here. Thankfully, it is turned a corner, and opiates are no longer used like they used to be used when I initially started practicing here in the United States. However, what opiates did was snub the pain. I have patients who have gone through that. They've snubbed their pain, worked more in the field where it is labor intense, and now they are into their 50s and 60s, not able to walk. Now they're dependent on opiates. It's a huge problem. And hopefully we don't have to deal with this with the future generation. So use pain and address it when it starts. Don't let it linger. Um, when there is pain, it means that some tissue is not aligned properly with relation to the other. Look at the kinetic chain, address it. Start with myofascial release. It plays a huge role. We know fascia plays a huge role in pain. So address it, limit it, move people from the escalating matriculation and keep them healthy earlier on, especially with children being more active and more involved in musculoskeletal um, injuries and conditions. So out here, talking about pain, I've used three different category of people again. So most of them in the bell curve fall into the middle category where they have aches and pains, injury to one particular joint, and then there's early maladaptation of the rest of the kinetic chain in front and behind that joint or tissue. So these are uh, people whom you can help earlier on and make them change. So using physical therapy, other alternative therapies here in the United States, we use acupuncture and chiropractic care a lot, as well as massage therapy. Ayurveda is something we can consider a lot more in India, I think, when it comes to musculoskeletal care. So these are definitely modalities we would use. And then Pilates to help with dynamic stabilization of tissue and orthobiologics in most of the people. And then there are the sideliners with severe disability and high functioning people with pain. So people with severe disability, unfortunately, some of the issues cannot be turned back. So you focus on maintaining and preventing progression. And in the high functioning, focus on strength training, maintenance, and the MAT, which is muscle activation therapy. I like using that quite a bit because when you tell patients, okay, you're healing from the injury, you've just had these injections, uh, go exercise, but don't exercise too much. So, what does that mean? So, the muscle activation therapy training is a good way of doing it. So, whatever exercise you have been asked to do, if you are not able to do more than five easily, then don't go to the next stage. You have to improve, you have to get better at that stage. And only when that's done would you move on to the next. So that's one of the lines that I usually like to use, and it actually is a eureka moment for a lot of patients. This again is a slide from my last presentation. So this briefly ran over all the steps with PRP injections. I will run through, I'm not sure how much time I have, but this is kind of the sheet that I give my patients and tell them what to do pre-treatment, what to expect during treatment, and what happens post-treatment. So pre-treatment, educate your patient enough so they are not surprised when you are telling them, okay, I'm going to draw your blood now. What? You're going to draw 60 ml of my blood? Am I going to be anemic? What's the repercussion? So educate them enough about the process. Avoiding certain medications which inhibit inflammation is absolute necessity here, because if you inhibit your platelets, there is no point putting these paratroopers into the area of injury. So there are tons and tons of different injectables and oral medications that can limit inflammation. So this is where you tell them, okay, don't stop your inflammation, stop the medications that can prevent inflammation, and get medical clearance wherever it's needed, especially in people with cardiac disease and atrial fibrillation. I've just listed out. So there are different recommendations. Different societies have, it changes from 48 hours to 3 days. So over ballpark, this is kind of what we use for injectable medications and for medications by mouth. I'm not going to go through these, but it's available for you to review later if needed. And then there are a lot of vitamins and supplements that you stop at least for 5 days. alcohol and nicotine has no role if you're planning if you're planning orthobiologics. Steroids are a definite no-no, especially in the area that you are injecting, at least for 4 to 6 weeks before your platelet-rich plasma injection. And we tell them not to do it at least for 2 weeks in any other parts of your body, or use it in systemic ways, so you don't have any systemic effect of the steroid when you're trying to do your platelet-rich plasma injection. If there is any acute illness going on, don't do PRP. Um, Tylenol is okay, or paracetamol or acetaminophen is okay for management of pain. Absolute contraindication would be any kind of hemodynamic instability, infection in the joint or anywhere in the body, platelet dysfunction syndrome, and usually if there is a late stage cancer, you don't do orthobiologics in them as well. During treatment, when they are in your office, make sure the environment is ambient, because they're going to be they're not there just for 10 minutes like when you're doing a steroid injection. They're there for at least 30 minutes to an hour, coming in, settling down, drawing blood, centrifuging, and then when you're injecting, you're not just injecting one place, you're injecting multiple different structures. So it definitely takes more time than doing a straightforward steroid injection or a block. So yeah, so an ambient environment, drawing the blood at least 60 ml, depends upon what kind of kit you're using. Our kits here are pretty expensive, so I draw as much as blood as I can. I make as much concentrated PRP that I can get and inject it in as many places as I can, and I don't just limit it to one place. Will they be sore? Yes, they are sore, but I prepare them for it and say,
Excuse me, ma'am.
okay, here's your benefit.
Hello.
And
Hello,
it
ma'am.
usually works. Sometimes patients don't come back. That happens, but that's how I like to prepare them.
Excuse me,
We
ma'am.
use ultrasound or fluoroscopy.
Hello,
I
madam.
usually use ultrasound for my injections. And we prepare them for the deep pressure like sensation that can occur, especially when you're injecting directly into the
Anupama, madam.
tendon.
Madam,
Sorry? Yeah.
actually, your time is up. Actually, we spent 32 minutes.
Okay.
Can
Yeah, sure. Do you want me to conclude, or I can
Yes,
stop,
ma'am.
whichever
Please
way you
conclude,
want to do
ma'am.
it?
Please conclude.
Okay. So basically, this is my post treatment. This is the centrifuge that we use, and the kit that can be used. There is a YouTube link to MSite. This is from the company itself that says how to make PRP. And yeah, staying hydrated is important. Post treatment rehabilitation process, usually you don't do significant exercise for the first 2 days. Starting day 2 to day 2 weeks, your exercise intensity increases, and then you have the second phase, which is proliferation phase, and then the remodeling phase, which goes on up to 3 months. So your recovery or your improvement from platelet plasma may not be completed up to 3 months from your injection. This is the same thing, slides, complications, nothing really other than pain, soreness, swelling, but which is the most common thing. Prepare them for that. The rest of them are just very rare. One of the things that I would like to mention is when we do injections into Achilles and patellar tendons, there is reactive tendon hypertrophy in some of the people, and that can be very painful. We don't really know why that happens. But if it does happen, then you have to come up with your next protocol to help calm that pain. But it is something that can cause longer lasting pain symptoms. Generally, in conclusion, it is safe. Listen to your patient, treat the kinetic chain. There's leukocyte rich versus leukocyte poor. Set expectations. Become part of the regenerative rehabilitation program, and remember to keep your treatment comprehensive, and use a multimodal approach. And this is my new addition to my life. He's taken more time than taking care of my children has taken. So I wasn't sure if this presentation will be ready on time, but it was. And thank you, and I hope it was helpful. Thank you.